I'm a retired pulmonary and critical care physician, and I've spent the last dozen years working for healthcare reform because of the experiences that shaped me in my career, trying to give good care to my patients and the frustrations that I shared with my patients. In the next 15 minutes, I'm going to discuss options for healthcare reform that fulfill the League's position. So to approach a discussion of healthcare, we need to begin by affirming our values. Is healthcare a commodity? And by that, we mean a substance or product that's bought, sold, or traded. Those are activities that require a market. And in healthcare, there is a market for health insurance policies and for some selected items like medications and hearing aids. But for healthcare services, there's a crucial difference. There isn't a market. The market concept simply doesn't apply. And this was explained by the Nobel Prize-winning economist Kenneth Arrow in a 1963 paper entitled Uncertainty and the Welfare Economics of Medical Care.
Excuse me a minute, Hank. Can we see your slides? Are you going to share those with us?
I thought that they were shared. I'm terribly sorry. Do you see them now?
All right, we do. Thank you so much.
Okay. So to continue, healthcare is not a commodity. There is no market for healthcare services. And for those who still insist there's a market, I would say that despite much effort at health market reform, healthcare is a lesson in market failure. So the predominant view is that healthcare is a necessity for everyone. And many people would regard it as a public good, which means it's a service that's provided without profit, so all can benefit. And examples would be public education or a fire department. And now I can't change my slide for some reason. So forgive me, let me go back. Ah, there we go. Okay. Access, cost, and quality are called the three pillars of healthcare, of a healthcare system. And despite the good intentions of the Affordable Care Act, access is still not adequate for the uninsured, but an even larger number of underinsured have difficulty with timely access because it's beyond reach due to the very high deductibles that are often beyond people's means. And the remedy here would be to redesign a healthcare system based on inclusion and equity that was so nicely described by Sierra. The second of the pillars of a healthcare system is cost. And the current healthcare system, I think, is universally regarded as costly at an unsustainable level. It's an enormous burden, not only for individuals and families, but for employers and for society as a whole. And the costs continue to rise to levels that are not sustainable. Many of you will recall Warren Buffett's comment that medical costs are the tapeworm of American economic competitiveness. And from a business perspective, the way healthcare is organized violates principles of fiscal responsibility because it lacks prudent and sustainable use of precious economic resources, economic efficiency, avoidance of waste, fiscal transparency, and accountability. So the remedy, of course, is fiscal responsibility and fair progressive financing and other details that would lead to a sustainable cost for healthcare. And I'm going to go into that a little bit in a moment. But let's talk about quality. Despite our technology and our highly skilled workforce, the US falls way short of other countries in life expectancy and in many other outcome measures. Sierra touched on the lessons of COVID-19, and I would just like to reiterate that it brought into glaring prominence the lack that many people have to timely access to testing and treatment. There was inept leadership in many aspects of how the healthcare system responded to the pandemic, and how the public health system fell short of keeping things in balance with the healthcare delivery system. We saw and became much more attentive to the vulnerability of our workforce and delivery system. We're experiencing the impact of systemic racism, and it's coming out in so many ways, but clearly in the context of the pandemic. And finally, we see the futility, really, of linking healthcare to employment. It's self-defeating, especially at a time when so many people are being thrown into unemployment and then losing their healthcare as a result. There have been many attempts in the past dozen years or so to try to address some of the deficiencies in our healthcare system through incremental change. And incremental changes force trade-offs between access, cost, and quality that are simply not necessary. So as we go down this slide, you can see that some of the changes that have been given the most attention, such as the Affordable Care Act, Medicaid expansion, public option, letting the free market do its whatever it's supposed to do, or imposing regulations on our private insurance companies, all fall short in fulfilling things that are fundamental to the values that we hold and to the position of the League of Women Voters. None of them, and I want to emphasize this, none of them would bring everybody into contact with the healthcare system. There would still be people who would be excluded from having access to healthcare because they lack insurance or they are in a plan that's unaffordable. Even within the Affordable Care Act, we see that. None of them would offer comprehensive benefits. Think of the things that are not included in even the Cadillac health insurance policies. How many policies include not only care for acute and chronic illness, but include long-term care, include mental health services on a parity with physical needs, and so forth. So none of these would allow for a choice of provider on the part of the patient. None of them would offer portability so that the individual retains access to healthcare through their participation in the healthcare system, regardless of whether they move from job to job or state to state. And none of them would achieve the affordability that's necessary because they simply leave enormous amounts of economic waste in the system. So none of these incremental changes meets the League of Women Voters position. Let's look at single payer, sometimes called improved Medicare for all. And I want to emphasize that we're not simply talking about the traditional Medicare extended to everybody. We're talking about an improved Medicare for all, which is different in certain key features. First of all, in access, It would cover everybody. So there would be equitability, no financial barriers, and reduction of disparities. The cost would be sustainable. There would be no profit in the delivery of healthcare services. There would be profit, for example, in pharmaceuticals, but that lies outside the interaction between the patient and the healthcare provider. So the healthcare delivery system would not be profit driven. There would be no private hospitals. There would be no private equity companies buying up health ambulances and hospice programs and other programs that provide direct services. It would be efficient and fiscally responsible. And as far as quality, it would be comprehensive. And what you see here are a listing of the things that are often left out of existing health insurance, such as behavioral health, as I mentioned, on a parity with physical health needs, reproductive health in all of its facets, all prescription drugs would be covered, dental care, hearing and vision aids, rehab, long-term care, and more details that I haven't even included. But what you can see is that virtually all of the healthcare needs that we experience in our lifetime, for which we look to the healthcare delivery system to provide, would be included in a single payer improved Medicare for all program. The other thing about quality is that by taking, by modulating and downplaying the money-driven economic imperatives that are having an inordinate influence on, for example, how long you can be face-to-face with your provider, how long your provider can schedule an appointment time with you. These things would be eliminated, and providers would simply be adhering to best practices. So the decision about diagnosis and treatment would be between you and your provider, and not by an insurance company that's looking at the money side of things. And then there'd be other attributes to an improved Medicare for all program. It would eliminate completely the need for Medigap and Medicare Advantage plans. There'd be simplicity, which would make things a lot easier for the providers, both physicians and clinics and hospitals that have enormous commitments to simply dealing with paperwork under the current system. There'd be security and peace of mind because people would have access to healthcare from the time they're born till the time they die without having to read the fine print and see if something is going to be excluded. And it's been proven to work in many countries, and we know from evidence that it would work equally well in the United States. So this is evidence-based policy. So here's where things stand. The league position is simply unfulfilled. The league created a position in 1993. You've heard what it is, and we're not there yet. We don't have a universal system. We don't have an affordable system, and we don't have a system that meets our expectations in terms of quality. But the league position is attainable through legislation. And I encourage everybody to actually look at the Medicare for All Act of 2019. This is the most recent successor to a long sequence of model legislation that could actually bring about the creation of a high quality, affordable, and universally accessible healthcare system. So this is House of Representatives Bill 1384, sponsored by Representative Pramila Jayapal from Seattle, and it has 116 co-sponsors. And if it were to pass in the House and Senate, and then signed by the president, it would then begin a process of conversion in a matter of just a couple of years to a completely transformed healthcare system that would meet the league's aspirations. Now, this will also entail some things that lie beyond legislation, such as effective program administration, planning and allocation of resources, delivery system reform, professional education, workplace development, improvements in public health, and addressing the social determinants of health. So we mustn't think that simply changing the payment system or the financing system is a panacea that's going to immediately give us the perfect healthcare delivery system. Perfection will never be attainable. There's a process of continuous quality improvement and adjustment, and healthcare has to keep up with the new discoveries brought to us by not only hard science, natural science, but also social science. So this is a continued quest, but none of these other changes can be fulfilled unless we change the program through which we deliver healthcare. So in the last couple of slides, I want to just touch on the question of the economics. And the way that economists can tell us how a single payer system or any other modification would compare with what we're paying now is to start with an estimate of the healthcare cost under the current system. And this is available on a national level. It's also available on state levels. And these statistics are updated every year by the federal government. So we know what the total national healthcare expenditure is. And if we want a single payer system that's comprehensive and covers everybody, we're going to have to add new costs to do that, to cover the long-term care, to cover the mental health or behavioral health improvements, to cover all the prescription drugs and so forth. So we can calculate quite well what those new added costs are going to be. But then we start to look at the enormous amount of administrative waste, something like $500 to $600 billion per year at the present time. We look at the excessive pharmaceutical prices, why in the US, the VA system is able to purchase pharmaceuticals for half the cost that the rest of us pay, why Medicare is not allowed to negotiate drug prices, why people in the US pay more than people in Canada and other developed countries. So these excess prices, not only for pharmaceuticals, but for other elements that have a decisive impact, will be eliminated because there'll be a negotiation between the National Healthcare Administration and these providers. And this negotiation will result in fair prices that will allow them to continue making a profit, doing research and producing good products and good services. But this is the way it works in other countries, and it can work this way in the US as well. And there'll be other service reforms. So taking the estimate A, so adding the new cost B, and then subtracting the savings C, brings us to the cost under the proposed single payer program. It's very simple bookkeeping. And in fact, I might add that this is not socialized medicine. It is, I like to tell my friends, it is socialized bookkeeping. And that's really what we're talking about here. So this is my last slide. And I would propose that single payer is really the only path ahead to get to the aspirations that the League put into its healthcare position in 1993. Now, when you go through these cost projections, it's been done in studies of high quality 22 times in the past 30 years. And every one of these studies has supported the potential for long-term cost savings. A reasonable estimate would be that the net cost of a single-payer improved Medicare for All system would be 10% below current costs. It may actually be higher, but this is a conservative estimate. And everybody will be covered and the benefits will be comprehensive. So how do we pay for it? Well, 60 to 70% of the total cost is already being paid for through current public funding. We don't have to change anything. We just continue the public funding that we have now. And this varies by state. Some states have slightly higher. In California, it's close to 70% of the healthcare expenditure of our state being funded through public funding streams. So all we have to do is replace the remainder, which is now being paid by premiums and out-of-pocket expenses. A lot of the premiums are paid by employers, but then they're taken away from the compensation of workers. So in the end, workers are paying those premiums, employees are paying them, and then we're all reaching into our pockets every time we need health care and paying out-of-pocket deductibles and co-payments. So we need to replace that with taxes. The beauty of the system is those taxes will be less than what people are paying now. And almost the entire population will save to a degree greater than $1,000. We're currently paying $11,172 per capita per year for healthcare, and $1,000 for every child, woman, and man in the country could be committed to other necessary expenditures like education, like housing, and so forth. The distribution of savings among people of lower, middle, and high income will depend on the tax structure. But again, almost the entire population will save. The taxes have to be progressive, they have to be stable. But I would just conclude by saying the obstacle to having a well-designed, evidence-based, policy-driven, humanly responsive healthcare system is simply that we haven't achieved the political will to do it. So I want to close with this quote: when the proposed policy is right and the politics are wrong, you don't change the policy, you change the politics.